Good afternoon, everyone. Thank you for joining us on today's session. So this is session number 5, this is session number 6, where we'll be continuing with our supportive care program. And on today's session, Erin will be talking to us about spiritually and the cultural appropriate care in supportive care. So I'd like to welcome all of you for this session. If you have any question or would like to ask for clarification, I'm encouraging you to use the chat, or you can also unmute and speak. So Dr. Mazal has joined us today again. So welcome, Dr. Mazal. It's good to have you in today's session. So welcome, Ellen, to introduce yourself and telephone.
Hi, everyone. It's really nice to see you all. I've been getting a chance to go around to the different clinics in the last few weeks. So I'm getting a chance to meet some of our champions in person, which is great. I had a chance to meet Fred and his team last week, which was really good. And we did rounds together, which was also really helpful and effective. And I'm hoping to be able to meet up with a few others on the group that are kind of in the Nairobi area. We'll have to talk with head office and see if I can get out to Tanzania at some point, but we'll see. We'll see how that goes. But thanks for joining this session. I know in reality it is really challenging to sometimes join on the IACO, so we do really appreciate when you make the time and effort. And I've been able to see how just engaging regularly with each of you, just doing some private messaging with the different champions and connecting has also been an effective way to really understand what you face each day in the clinic. So please don't be a stranger. Most of you know me by now, but my name is Erin. I'm a palliative care nurse originally from Canada and now live in Kenya, and we've been living here with our family for the last 5 years. And I have been with AHN for several months now, and this is not the right slide. I've been really encouraged to see, even just in the last few months of working with AHN, to see that people are quite interested in learning new concepts related to supportive care, and yeah, exciting things happening. So. All right, Dr. Azael, have I given you a headache with switching my screen over so much? Can my screen now? Is it working properly?
Yes.
Okay, sounds good. Okay, so everyone, today we are going to be talking about spiritual care. So sometimes as a clinical officer or as a nurse or as a nutritionist, we obviously have a variety of providers in our champion group. You may not necessarily think it's your job to think about the spiritual aspects of a patient and their family. But as we learn more and more about supportive care, we actually have the privilege of engaging with patients and really beginning to try to understand their spirituality and how this can affect their health and especially their quality of life, which is what we talk about in supportive care. So that's what we'll be focusing on for today. Again, this is part of our supportive care program. We will be discussing, we have 12 different topics in our course, and you guys are the first group that's gone through this program. So again, if you have any feedback, please do let us know. We're always looking for ways to improve the program. So please let me know for sure. Just send me a message or email. I do want to give credit to the group that I was able to adapt this content from. So one was Joan Marston. She's a senior nurse and has been working in the field of palliative care for many, many years in pediatrics in South Africa. And I also was able to adapt some of the content from a lecture from the University of Calgary from Dr. Angela Ferguson in terms of addressing spiritual issues in palliative care. So by the end of the session today, I'm hoping that we can together begin to recognize and address our patients' spiritual and sometimes even their cultural needs. We're going to find ways to access spiritual care providers, especially when that's necessary. Sometimes there'll be issues that are beyond our ability as general supportive care providers. So we do need to find ways to reach out to those around us, and then finding ways to respect and integrate diverse belief systems into the care we give. So there's a possibility that you will be giving care to someone that may have different beliefs than you do. And part of this course and the session today is really beginning to understand that ourselves. So we're hoping that also by the end of the session, you'll feel more competent to be able to address patients' spiritual and cultural needs. And we know, of course, this also does take time to develop that confidence. But hopefully over the several months of the course, we can work together to get to that point. So just a quote to start us off by Dr. Anne Merriman. She's a physician that started palliative care more officially in Uganda many, many years ago and has worked with Ugandans and is still based in Uganda. And she said, spirituality is the journey. Religion may be the mode of transport. So when we think of the words religion, spirituality, spiritual beliefs, they're not all exactly the same. And that's something that you may come to a better understanding or a different understanding after the session today. So in 2015, Mark Bartel shared some quotes about spirituality and what is spiritual suffering. So in the reference here, they quoted that humans universally have the basic spiritual needs for love, for faith, for hope, for integrity, and for beauty. Spiritual suffering, though, is experienced when these needs are not fulfilled or they're unfulfilled. Spiritual care, and some of that is what we're going to be talking about today, involves assisting in the fulfillment of these needs. So the needs of love, the needs of faith, the needs of hope, integrity, and beauty. So an international consensus definition of what spirituality is related to our field of supportive and palliative medicine was done in 2014 by a group of providers. And they said that spirituality is a dynamic. So it's always changing, it's moving, it's shifting, and it's an intrinsic aspect of humanity through which people seek meaning, purpose, and transcendence. And they experience a relationship to self, to family, others, community, society, nature, and the significant or the sacred. Spirituality is often expressed through our beliefs, values, traditions, and practices. This is really helpful that we all are kind of on the same page when we think about what is spirituality. So the National Cancer Institute, along with several others, also have shared what they feel spirituality is. And they've said that it's an individual's sense of peace, purpose, and connection to others and beliefs about the meaning of life. Others go on to say that it's the feelings, thoughts, experiences, and behaviors that arise from a search for the sacred. And the individual's beliefs, values, behaviors, and experiences related to ultimate meaning. And I think all of these definitions and kind of phrases and understandings of what spirituality is really should help us identify that spirituality is not synonymous or not the same as religion, but it may be interconnected. So when we talk to our patients about their spirituality, we don't just want to know what religion they believe in or what church they go to or what mosque they attend. It's beyond that. Of course, it's connected, but it is not only the religion that we're interested in. So another way to look at it, or a visual for people that are more visual, the core elements of spirituality of a person. Obviously, we have hope at the center. And then we also include meaning and purpose, transcendence, mystery and paradox, as well as that connectedness with self and family and sacred or whoever you believe in. So many people believe in God, but people believe in different higher powers. So why are we talking about all this today? So what are actually the spiritual needs of our supportive or palliative care patients? What are the needs of our patients in our dialysis clinics. That's actually the reason we're talking about this today. That's why you've signed into the call and you're curious to understand a little bit more about this. Well, some research has been done. This research is a little bit older, so from 2001 and 2014, but it showed that the spiritual needs of patients that have a serious illness or who would benefit from supportive care or palliative care stated that they needed someone to listen to. They had concerns for their relatives, and they also had spiritual needs of having someone to be there for them. The second research shows there that they need to be recognized as a person or maybe as an individual, the need to know the truth about their illness. And the least important spiritual needs were continuity and an afterlife, to get rid of obsessions and to achieve freedom from blame or to be forgiven, to forgive or forgiven. So that's kind of interesting. Sometimes we do think about people and their spirituality, and we talk a lot about heaven and the afterlife and these kind of things, but actually our patients from the research in 2014 showed that those weren't some of the most important needs that our patients, that the patients in that research study shared. Here's some information from an interesting group. They're called the International Working Group on Death, Dying, and Bereavement, and they also identified some questions that patients and even families begin to have when they experience a serious illness. So, of course, we're talking about kidney failure, advanced kidney disease as the illnesses that our patients are dealing with. So patients may ask questions like, who am I? What am I doing here? What is the meaning of life? Why is life so unfair? Why do I have to go on living? Where do I fit? Why does God allow this? Is there a meaning in the suffering? Why do I have to suffer? What is the meaning of my life right now? What has been important to me in my life? Is there life after death? How will I see my loved ones again? And have I made a difference? These, again, are some really interesting questions that probably on a regular basis we don't really talk to our patients about. And again, actually, during our session with Fred last week, we identified that probably we wouldn't be having some of these more in-depth, intense conversations with our patients every time they come to the clinic. But actually, it was rewarding to be able to begin to allow ourselves to have more serious conversations with our patients. And Fred can probably share a little bit more about that at the end of the session. But sometimes we will engage in these kinds of conversations, and especially as you've engaged as a champion and so the supportive care program, we are going to be looking to you to find support and you to kind of spearhead some of this work in your setting as you begin to feel more confident. So we do know that our patients experience distress. We know from the last several teachings that sometimes that distress is physical. It can be an emotional distress. Today, we're going to talk about spiritual distress. So one of the ways we can talk to our patients is by asking them if they feel at peace. Spiritual well-being can be understood as a feeling of peace. So asking a patient if they feel at peace may be too vague. It may not be a clear enough question. So we'll get further on in the session to helpful questions to ask as we begin to assess this. But we know that spiritual distress can occur when people are unable to find their source of meaning, when they're unable to find sources of hope, love, peace, comfort, strength, and even a connection in their life. This distress or this spiritual distress can actually affect their physical and even their mental health. Serious illnesses such as kidney failure, which we've talked about, can cause this type of distress in patients, as well as in their families and friends. How do we know if a patient is in distress? Of course, we do need to assess this and we need to ask them, but some indications of a patient suffering from spiritual distress is a fear of loneliness or abandonment, not accepting of their disability, being unable to enjoy activities that used to give them pleasure, having disconnection, or even a fear of death and dying and the unknown. So when we think about assessment, there's a few tools we can use. So this one is called the HOPE. As you can see here in the black letters, if you're looking on your phone or on your computer, you can see HOPE are in black letters. This can kind of help you remember the kind of assessment tool. So the first one is H, so hope. What are the patient's sources of hope? Their source of meaning, their comfort, strength, their peace, their love, and their connection. You can then ask them if they're part of an organized religion. Again, we said spirituality is not the same as religion, but we know that many traditions and practices of spirituality are organized through religion and through denominations and through different groups of people that gather. So maybe they are part of an organized religion. Do you have spiritual practices that help you? So the P is for practices. So this could be, an example of this could be prayer, could be singing, could be worship, could be spending time in nature, could be journaling or reflecting. And then the last one is E. What effect does this have on a patient's medical care or their treatment? So being part of an organized religion or having a source of hope, does it affect their care? Does it affect their treatment? Does it affect their current situation that they find themselves in? And then you would ask them about that. And then, of course, we need to make sure when we do these types of assessment, we also want to document what we found. The second tool is called SACRED, S-A-C-R, and then there's no E, but it's a space, and then D. So this is a framework for communicating to our patients about their spiritual issues. So this was developed in 2011 by Sinclair and Chochinov, about how to support our patients as we begin to talk more about their spiritual concerns and their spiritual issues. So the first step is self-awareness. So we as providers need to be aware of our own spirituality and our own beliefs and values, so that as we engage with patients, we're not necessarily, we're aware of our own so that we can be also aware of theirs. We need to understand that not all of our patients and not all of the people that we engage with will have the same beliefs and values that we do. We then begin to assess the patient. So you can use that HOPE assessment tool, begin assessing their spiritual distress. We then can offer a compassionate presence. So we've talked about compassion as showing empathy, sitting at eye level with a patient, finding ways to understand them as a person, and just being there. Sometimes it can include touch, so offering to hold their hand if that's appropriate. The fourth step is relational support. So this is where we need to potentially engage with a spiritual advisor. Sometimes that could be a pastor. It doesn't have to be. In some of our referral settings, there are chaplains who are spiritually trained individuals that also understand the nuances of healthcare and obviously spend most of their time in health facilities supporting patients. And the last step is to continue the dialogue. So as we assess, as we provide a compassionate presence, as we refer, if necessary, for more support, we continue to engage in a dialogue with our patients and our families about their current situation and their spirituality. It's really important as we give general spiritual support as providers to listen to people's story and to show compassion. We don't need to give answers or give advice, because sometimes that includes us imposing our own beliefs and values on other people. We want to use prompts such as "tell me more about," or "what does that feel like for you?" or "how do you know when you feel better?" These are good ways to engage in an open discussion. We want to avoid any sort of false reassurance if the person is talking about death and dying. We don't necessarily want to give false hope to our patients, actions of family and friends. Sometimes it also is through creative activities such as music or art, and then often through support of a religious or a spiritual leader. Some people might feel assurance by knowing that their questions and struggles are experienced by many facing life-limiting illnesses. So you could potentially share that as they talk about their situation, that potentially if there were other patients that had also shared something similar, they might feel reassurance from that as well. Of course, continuing to abide by confidentiality and not sharing personal information with other patients. So I want to show you a quick video right now as we continue in the session. And this one is about compassion. So it's a short video by a researcher called Brené Brown. She's also an author. And she is defined, and along with many others, that compassion is to suffer with. It is a deep understanding of the suffering of others coupled with a wish to relieve it. Compassion is not sympathy alone. And this video, I think, explains this really well. So we'll just watch it together. I hope it works. Let me know if you can hear it.
So what is empathy and why?
Azil, can you hear it? Azil?
Yes, Erin.
Okay.
You can start over.
Yeah, I think I can hear
Very
it.
different than sympathy. Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, I'm down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? It's a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. I had a, yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. I had a miscarriage. At least you know you can get pregnant. I think marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conscience, better. If I share something that's very difficult, say, I don't know what to do right now. Truth is, we're
Sorry. Oh, thanks.
response make better. What makes something better is connection.
So just as we continue for today, I want to take some time to do some self-reflection. So I know, again, regularly it's hard in the clinics to do a lot, because I know you guys are overwhelmed with patients and there's other colleagues around, but I want you to think of these 4 questions and either write a note on your phone. I can also share these on the WhatsApp group after, but our interaction and activity for today is to do some self-reflection ourselves. If we are going to consider engaging with our patients, we also need to engage with ourselves. If we are going to think about talking to our patients about their emotional situation, what they hope in, what they find meaning in, we need to do it ourselves. So we're going to take a few minutes now, after you've heard a little bit more about compassion and showing empathy to patients. I want you to think about these 4 questions. So the first one is, what gives your life meaning? If we were to ask one of our patients this, or maybe a caregiver, it would hopefully give us a better understanding of who they are as a person. We would learn more about their values, what gives them interest in their life. So I want you to also answer this question. I'm going to do it myself. So the first question is, what gives your life meaning? And if you, we won't put this on the chat, but again, if it's easier for you just to type it to yourself, I think on WhatsApp you can actually message yourself. Just write it down somewhere. The act of writing things is also kind of therapeutic and meaningful in and of itself. The second one is, what is important to you? So again, if we're going to eventually start engaging with our patients on a different level, rather than just wanting to know what did they eat for breakfast, we're going to want to know more details about them to find better ways to improve their quality of life. We also need to think about some of these questions ourselves. So the second one is, what is important to you? Number 3 is, what do you enjoy, or what makes you happy? So what do you enjoy and what makes you happy? And then the last one is, who makes you happy? And then who do you love? So this is just a short kind of exercise that we can engage in to better understand what our values and beliefs are. And of course, this is not an extensive list of questions, but can actually begin to think and help us as we engage with our patients at the same level. I'm going to share an image with you now. This is an image of a sculpture. And the image is of spiritual suffering that comes from a lack of meaning and purpose. Being disconnected from what's essential for spiritual integrity. So here you can see this very vivid image here, and it's of a person. And you can see there that there's so much missing from the person. There's distress as they hang their head, their arms are over their legs. To me, it seems very much like this person is completely empty. Although they seem to be there, they have being in the sense of their arms, their legs, their mind. It seems like here they could lack faith, hope, beauty. And we know that not all of our patients will experience extreme distress and spiritual suffering. But today you might be learning a few things that you might be able to notice in your patients. And this is important. We need to make sure we don't ignore some of the signs that our patients are showing us. We know that grief can cause a lot of distress. We know that grief can come up in a variety of ways, and dealing with grief can also be really difficult. We know that patients can feel angry, they can get depressed, they can be in denial. But we know that grief is one aspect of a patient's being. It is, as we talked about last time, it's not a mental health issue that needs to be solved. We need to find ways to engage with our patients that are experiencing grief. Some people might think that grief is a cycle. So it starts with the denial of having a serious illness, then moves to anger. Then you begin bargaining with God or your family or the doctor. Maybe you get depressed. Eventually, you finally accept the fact that you have kidney failure. When in reality, grief can be very much like this red arrow here on the very far right-hand side. It can be complicated. Our patients can feel a variety of emotions. They can have doubts at any point. They can feel happy and feel like things are much more manageable, again, at any point. I want you to remember about this last week as we talked about the emotional realities that our patients face, is that there's no one way to grieve. Our patients can't be expected to grieve loss of their job or the loss of their role as potentially the breadwinner or as the person that's doing most of the duties at the house, we can't make fault for them if there's days when they're feeling really upset or where there's days when they're angry. They're grieving the situation. There's no right way to grieve. Grief does not travel in a predictable pattern. It doesn't disappear, it changes. Our job is not to fix their grief over the fact that they no longer can work or that they're no longer able to drive or they're no longer able to travel on public transport by themselves. It's our job to walk with our patients through their grief. Again, to sit with their suffering and engage with them in a compassionate way. Again, some people believe there's stages of grief that happen very succinctly. Patients have a shock, they feel numb, they're in denial, they get angry, they start to have loneliness, potentially they get new relationships, they have more hope, they begin adjusting. But in reality, look at how complex and mixed up and all over the place grief really is. So in conclusion, when we think about our patients' spirituality, when we think about patients experiencing distress and spiritual distress, when we think about their suffering and the compassion that we can show them, when we think about their grief and all that they've been through, I want you to think of this quote from a psychiatrist and Nazi concentration camp survivor who said, "Man is not destroyed by suffering. He's destroyed by suffering without meaning." And I think that we, as a group of champions that are interested in finding ways to support our patients in a holistic, supportive care way, need to help our patients find meaning in their life, find meaning in their situation, find meaning in their disease. And I think that's what we hope that this program will increase your confidence in. And yeah, I'm really interested to hear if anyone has any questions. These are some of those questions and reflection questions that we talked about. And again, I can put these in the chat. Just some of the references and resources, and I'll share that. But does anyone have any questions? We have a bit more time. This lecture is not as long. So I'd want to open it up for a time of discussion, if you feel comfortable.
Thank you very much, Erin. So if anyone has a question or they'd like to share their experience, particularly in this matter, you're welcome.
I don't think this is a topic we talk about very much at AHN. Is it, Dr. Azale?
Probably not. This considered to be like personal life or personal stuff. So very, in very few moments, you might be involved in talking to the patient with these topics, but it's a good thing.
Yeah.
Doing things from this perspective. Yeah.
So, hi, Erin and Dr. Azael.
Yes, welcome.
I think it is not the matter that the topics is not familiar attention because I've been having a huge gap in this area because most of the patients will actually suffering some mental issues, social issues. So the way to address them or approach them and maybe discuss or have a deep conversation regarding their personal issues has been an issue for us because we were actually not having someone who is qualified or someone who is trained to take part, especially in social life of the patient. So as a result, we have been having some of the issues among the patients where the patients will actually having a non-adherence, not having adherence on dialysis treatment, suffering from family issues, social issues. So those then come as a result regarding the patient status, either clinically or mentally or socially. So we have some of the cases we tried to manage according to our level of understanding, if I can say. So, but since this spiritual approach can be incorporated in maybe in the care we give to the patient, giving our time to our patients. So it can be very, very helpful for us and patients as well. So for me, I can say that I have learned a lot from this presentation, because so I can even realize that we still have a long way to go to make sure that this is being happening on a regular basis. So having some deep conversation and patients, knowing how we can approach them spiritual, knowing how they are doing spiritually, socially. So it is some of the things we can base on and have maybe the better outcome for our patients' status and family. So thank you so much.
Thanks for sharing that. Fred, you have anything to add or would like to speak anything?
This week, actually, when we went to, or last week when Fred and I had our meeting, we didn't actually get a chance to see many patients, but we had an interesting case of a young boy who was 15 years old. And I do think in certain situations where the socioeconomic situation is beyond our control at AHN, when families feel very desperate, we can also feel like our hands are kind of tied, right? If only we had more money, the patient would be in a better situation. If only this, if only that. And I think that can be very distressing. I mean, Fred and I didn't feel like we could kind of walk away from the situation, because we did really feel like there wasn't much that we could offer to the family. The situation was quite overwhelming. The mother had to begin to source funds for transplant and this and that. And I'm sure it's very similar to a lot of the situations that you guys face in your clinics. And we offered the mother time. We spent a lot of time with her. We allowed her to share her story. Fred had said he'd been working with the patient for several months, and some of the things that the mother shared were things that he hadn't even heard of before, which is, again, we weren't necessarily coming in saying, here's 100,000 shillings, sort your family out, sort your life out. That's not what we were offering. We were offering her a moment to think about what was happening. We were listening to her. We were providing compassion. We told her that we didn't have necessarily all the answers of why this was happening, what was going on, what were some of the solutions. And I think that can be really hard as clinicians, because we often engage with patients and we often are the ones who have the answers. We know exactly how much medication they need. We know how long they need to be on treatment. We know what to do if their blood pressure is high or their blood pressure is low. And I think sometimes when we engage in these kinds of conversations where it's more emotional or psychological, social, spiritual issues, we, again, may not be able to solve all the issues. And I think that's not what we're expected to do. And I think that's a shift for us. Allowing someone to talk about what is going on, again, is not necessarily going to solve all their problems either. It begins the therapeutic relationship with them. And I think hopefully some of that you can learn through this course and this program. Having some skills, practice will help. So engaging regularly and talking about emotional and psychological and social issues with patients, although it is hard and it's draining, doing it often can help you feel more confident in it. And then when you have patients that are really, really angry or showing that intense spiritual distress, finding other people to support us. So again, the chaplain, if there's a chaplain at the facility, if there's a need to refer them to a psychologist. Again, we know these things are sometimes expensive, but if a patient is really struggling, we would the same way we would refer them to the nephrologist if their lab work was kind of off. We need to do that as well for their spiritual concerns too.
Well, thank you.
So next week,
yes.
Yeah, next week we're gonna start with our case presentations. So the team in Rwanda has put together a case So that'll be quite good. We will continue with the teaching aspect, but it will be a little bit shorter. So next week we're going to talk about shared decision making. So again, is kind of a topic that we're not always actively involved in because of the way the system of AHN is, where a lot of our patients come in already having decided that they're starting dialysis. And of course, we don't have the specialists with us every day to have some of these discussions directly with patients. So we're going to look at that teaching, and then the team from Rwanda will also share the case that they have prepared. So yeah, think again of when you are able to also prepare a case. I think we've had 2 people sign up for the next several months. But if you guys are able to also sign up, I know it's a good way to learn as well.
Thank you very much. Okay, so as always, I'd like to wish you a good evening and hoping to see you in the upcoming sessions. Very much, Erin.
Thanks, everyone. Thanks, Veronica. Bye, Fred. Bye, Francis.